Personally, I do not know of any research articles that suggest this, but most probably it's out there. You can go back and look at it. But what we know is that there's some more recent data that shows that the prevalence of dementia, at least in the Western world, is actually coming down. So it's an association study. It suggests that if you smoke less, you exercise, you look after your health, like what was mentioned, the chance or the risk of you developing dementia actually drops. So if that were the case, and this is a surrogate in terms of examining, certainly watching for pollution, eating healthily, that type of thing, especially if it's long term, is something that needs to be looked at, and certainly I think would increase, at least professionally, I think may increase the risk of dementia. As for President Biden, right? The truth of the matter, if you remember, the diagnosis of dementia is a clinical assessment on function. So he may slow down, he may not be as sharp, he may have word finding difficulties, he may actually be not so quick on his feet. But still functioning, right? Then it's very difficult to label him as having dementia. And that's, again, the blessing and the curse of being high functioning, right? Because if you're high functioning, you compensate until a point where you then cannot compensate and then you label the person as dementia. So it's a blessing and a curse because your diagnosis may take time to be made. And I hope that answers the question. Someone, if I'm not wrong, in the 1990s, early 2000s, has actually thought about this. So they developed a vaccine for dementia, but they didn't test it on humans, they tested it actually on rats. This is a study long ago, and the intention is not to scare people not to take vaccines, because the vaccines are really very safe. If it's effective, it will be useful. But in those studies, it showed that although very effective in reducing the amyloid plaques, there was some reaction to the vaccines. I think because of that study, a lot of time people don't want to give something that's permanent. Right? So moving down, at least from my understanding what happened, people look at the same function, increasing your immune system to get rid of the amyloids, which is what the monoclonal antibodies actually do. But I have not known a recent sort of study in terms of vaccinations for Alzheimer's.
So that's a two-part question. Let's talk about FDG first. So FDG is just sugar. So what the patient goes through is that we set an IV plug in the hand, then we inject the sugar tracer in, then we ask the patient to lie down, rest for about 40 minutes, and then you go for the scan, which takes roughly 10 minutes. For brain scans, there is no need to fast, you can continue having your breakfast, so it's a very straightforward scan. Not encountered a case of a patient being allergic to sugar at present. For the amyloid tracer, the risk of allergic reaction is also very, very low. Incidental reports, none encountered in Singapore. The scan is also very straightforward. You go in to the scan room, we inject you, you rest roughly 20 minutes, the scan is 10 minutes, and that's it, you go.
Memory, I guess, is a label from a layperson point of view, but from the psychiatry, the medical, the geriatric point of view, there is formal as well as informal type of assessments. So we start worrying when you say, I forgot to turn off the taps, I forgot to turn off the lights, I leave the stove on, I forget the way, I can't use the numbers, I can't call as familiar as normal. I didn't put the salt in the food, that's why the food tastes a bit different. So those are like screening for us to then be worried. Then you may then do more formal assessments in terms of actual battery or test. The question that was mentioned, does Biden have memory problems, and then Trump challenged him to do the test. So it's something like that, right? It can be a test because we suspect something is going on, and the test can actually be quite extensive. So I hope that answers the questions in terms of the memory assessment. So when the layperson brings up these symptoms, a battery of evaluations from the clinical, and then the formal will be done to evaluate whether the memory impairment is significant. To answer the question of whether it's short-term, long-term, usually the last things come out last. So your short-term memory is affected usually first, and then your long-term memory. So it can sound unusual, right? You said I cannot remember things long ago, but today the things I can remember, it does not fulfill the pattern of dementia. So that's where more scans, more evaluation, looking at whether there's a psychological or medical issue becomes even more important. Those are my inputs at that point. This is my time now.
The amyloid scan, very long term. As mentioned, it can pick up deposits 10 to 20 years before the onset. So if you have a clear amyloid scan, there's no real need to repeat it every year, every 5 years. I would say you're quite confident for 1 decade. You can repeat it 10 years down the road, but chances are that will be normal as well. Okay? For the FDG PET scan, that's a bit tricky to answer. So there's quite a number of referrals from the NNI, and it's not, the cases are sure is quite frank, but some cases we see very unusual patterns, and if we are unable to come to a specific diagnosis and the patient has very vague symptoms, what we recommend is a interval follow-up in 1 year. Because at a 1 year interval, we can see very distinct changes happen that will point towards a diagnosis. But saying that, if your FDG PET scan is essentially normal, right, and the clinical symptoms are vague, there's no real need to repeat it in 1 year's time. I'll say you are okay for the next 3 to 5 years. When you come for the scan, it's not only the scan. We actually ask you to do a memory assessment as well, and I interpret the scan in conjunction with the small memory test, the MMSE. I actually call the clinician to get more history, so everything is taken to account when reading the scan.
If you follow the talk before, the behavior needs to be a change from the person's baseline. So if addressing this question, if someone's repeatedly asking questions, this is a change from before. Because if it's like that all the time, then from a psychiatry point of view, I'll be asking, is this person anxious? Right? Is there something about this that they keep wanting to ask the question? But if this is a change from before, not anxious before, don't have these problems before, then I would suggest that there may need for evaluation of dementia. Now, the diagnosis or what you are seeing is actually just a screening. You suspect, and therefore the assessment needs to be done. But dementia categorization results in mild, moderate, and severe depending on the person's function. So broad headings. If the person is still looking after their BADLs, basic activities of daily living, behaving, feeding, changing, toileting, walking, and they're totally independent, usually it's just mild. When they start needing help for this, not because of weakness, not because of physical frailty, but they cannot do it, then you worry whether this is moderate. And finally, of course, when everything needs to be helped, then you're talking about more advanced stages. So again, to answer therefore the last question, right? I mean, why 2 years and then things get so bad? Is this an association? I think the overall global assessment needs to be done. In general, people do not pass away from dementia. They pass away from the problems of dementia, lack of care, physical health deterioration, and so on and so forth. So it's not just a clear-cut association with this disorder and then 2 years, or this disorder and then 1 year. It's not so clear-cut. The final thing, I guess, is a bit of clarification. Dementia is a big category, right? Neurodegenerative disorders is a big category, just like cancer is a big category. Everybody hears dementia, very frightened. Just like everybody hears cancer, very frightened. But there are all sorts of cancer, skin cancer, lung cancer, brain cancer, liver cancer. So that there are different categories of dementia. Alzheimer's being the most common. 70% of people that if you label with dementia will have Alzheimer's. So that's the difference. So dementia big category. Alzheimer's is one of the commonest dementias, but then you have stroke-related dementia, you have Parkinson's-related dementia, you have like Muhammad Ali, right? Contraindications dementia. So there are different types of dementia within the big category. 55 years old is a bit early for dementia. And so generally, if this is the case, then some form of evaluation would be needed. At this point in time, as I mentioned in the talk, dementia is a delaying type of process. So there's no, I didn't answer, there's nothing magical at this point in time, but as I mentioned, I'm hopeful in 5 to 10 years' time. And usually, when things come out, my cost is higher. But when it shows its benefit, as I said, in terms of the $500,000 a year, that will when it changes and hopefully will be available for everybody. So in this particular case, there's no magic pill, but when it comes and it shows to be that effective, certainly there will be a big reason why we should be having it for everybody. But in this particular case, unfortunately, there's no magic pill. So it's delaying and coping and adjusting, as what I mentioned. And unfortunately, at least at this point in time, this is a strategy. This is a strategy that I guess if you go to the clinical aspects, you come and see me in clinic, this is what we will really need to discuss in terms of the management.
What are the preventive measures?
Andrew mentioned a few, right? In terms, it's all now, really it's all now. Right? But again, lifestyle changes are very painful. You know, it takes a lot of discipline. Right? But it's now. If you wait till the signs come on, it's honestly a lot of people do sudoku. I said, already 20% of the amyloid, you know. So they are, but the truth is that you need to do it now. Right? So again, upstream, I'm a psychiatrist, I talk to the old people, but I hope that the young GPs and that start all this move the needle backwards. Because by the time you say like that 50-year memory problem, it's a bit like a house is on fire, and you're fighting to try to put it out. So as much as we want to deal with this, we want to also do the public health thing to actually do things much earlier. That's where the family, in my mind, the family decision that someone coming in to walk with family and something so important.